It's the oldest city in the Netherlands, about 2,000 years old, so not as old as China, but still reasonable. And I'd like to talk with you about functional changes during lead bundle area pacing. And I'm more a mechanical person of training, and with mechanics I go deeper than ejection fraction, which is, in my mind, a limited measure. Of course, much used, but I also like to understand better what's exactly happening. And also, we almost always looked at left ventricular ejection fraction, but what happens with the right ventricle? Because with left bundle branch pacing, we may induce a right bundle branch block. And how good or bad is that? So this is our history, because we started more than 20 years ago with positioning a handmade simple electrode across the septum in dog hearts and showed already a very good hemodynamic response, much better than right ventricular pacing. And then a couple of years later, we used chronic pacing in dogs as well and looked at the chronic effects. Let's see. Okay. So we were able to use a modified 3830 lead with a longer screw that Medtronic made for us to position deeper in the septum. I must say that we never, at this time, looked for capture of the conduction system, so we refer to this as left ventricular septal pacing, but our definition, I think, we are pretty deep in the septum, so really close to the endocardium, but we never checked conduction system capture. Nevertheless, so we measured with MRI tagging, which is a highly detailed speckle tracking technique, but in the MRI. And these are polar plots of contraction, and blue is shortening. This is the normal conduction, sinus rhythm. Everything is blue, which means it's very uniform contracting. On the other hand, right ventricular pacing, you see the septum is red, and that means very low contraction because of the mechanical dysynchrony. And then with the LV septal pacing, you see a very nice uniform distribution of the strains. And we took some measures, calculating from all the data about mechanical discoordination, which is based on the entire shortening patterns, and the time to peak, which is mechanical dysynchrony. And in both cases, the LV septal pacing were very close to equal to the normal conduction, whereas right ventricular pacing was worse, much worse. This also translated into better contractility, measured as left ventricular DPDT. In LV septal pacing compared to the sinus rhythm, no change, whereas we see a 30% decrease with right ventricular pacing. And also we measured stroke work by pressure volume loops and oxygen consumption by coronary artery sampling. And we see that right ventricular pacing has a 40% lower efficiency, so you need more oxygen for the same stroke work. And this is completely normal in left ventricular septal pacing. That led us also to the first, what we call again, left ventricular septal implant with the same prototype lead from Medtronic in a sick sinus patient. And we again saw no change in DPDT in left septum pacing, whereas a decrease in right ventricular pacing. And notice this is 1 year before the famous Dr. Huang paper. But we also continued to study acute hemodynamics in CRT patients. Well, here we see the decrease in Q restoration, QRS area, which is a more detailed measurement, which is better than biventricular pacing. This is ECG imaging, where left ventricular septal pacing is better. This is DPDT again, the same increase as biv pacing, and notice also the same as his bundle pacing in a couple of patients. But then again, and this is indeed the famous case report of Dr. Huang in 2017, where he had the courage to use the regular lead. We never dared to do that, honestly, because we thought the screw was too small, but he managed to capture the left bundle branch. And so the world has changed, And the big question that we were left with here is, so what about mechanical desynchrony and discoordination in the current left bundle area pacing? And are there differences between selective and non-selective left bundle area pacing and LV septum pacing? And again, how is the right ventricle influenced? So really detailed measuring the mechanical discoordination is done by speckle tracking, echocardiography, where you see the septal motion starting early but a big and complex rebound pattern occurring, whereas the free wall is being pre-stretched and then shows a continuous shortening. And if we then combine that with left ventricular pressure measurement, you can make a strain pressure diagram, which is very wide in the free wall and is very complex and with clockwise and counterclockwise parts. And the red clockwise part means negative work done. So there's work done on the septum rather than by the septum. And this results in a very large difference in work between free wall and septum. And this is typical for a good CRT response. So this study by Mao, actually this is all very recent work now, and I'm glad this is coming along. They use the same system to measure speckle tracking and calculate work in right ventricular pacing and left bundle pacing. And you see here how right ventricular pacing can induce the same mechanical desynchrony, both post-implant and during 6 months follow-up, and how the left bundle area pacing very minimally influences this discoordination, although maybe a slight worsening over time, but still much better than the right ventricular pacing. And if they calculate then the regional work, you see the decrease, the strong decrease in work by right ventricular pacing and a minimal decrease in left bundle pacing. And the sort of work difference between about is very large in right ventricular pacing and minor in left bundle pacing. So supporting all the ideas we have that resynchronization by left bundle pacing is indeed working. This slide was a bit off, apparently, but to understand really what is going on in the heart, we also went to a computer model in our university, which contains fibers, which contains also, as you see here, a Purkinje system, and we simulate the activation done by the heart. And the beauty is that at least we know for sure where the activation really starts. We suppose some things, but at least we can mimic that. So this is selective His bundle pacing, which is basically sinus rhythm, and you see the synchronous activation in the two ventricles from endocardium to epicardium. This is selective left bundle branch pacing, where the left side is completely normal activated, but a delayed right ventricle, so a right bundle branch block-like situation. With non-selective left bundle pacing, we have also some early capture of the septum and then translate in a little less delayed right ventricle. And if you then go to left septal pacing, we lose the activation by the activation system, but so we have a slower left ventricular activation and the same right ventricular activation as in non-selective left bundle branch pacing. And we use that data to bring it into segments, and those segments we input the electrical data in a model which we have for many years coupled to the circulation, so we can calculate blood pressure, cardiac output, but I would like to go now into the strains in every of these segments where the electrical activation time is used as a start of contraction. And we can generate strains like in speckle tracking, and you see the red is the septum, the dark green is the left ventricular free wall, and this is the right ventricular free wall. Of course, they are pretty similar in His bundle pacing, right ventricular pacing. You get the desynchrony, as we all know. In bifid pacing, it's pretty well corrected, but there's a large variation in strain between the different segments, the shaded areas. So with left ventricular septal pacing, what we see is that the septum indeed is early activated, but the right and the left ventricular free walls are now simultaneously contracting. So indicating the very small interventricular desynchrony. And then if you go to non-selective left bundle branch pacing, it's slightly different because the right ventricle is getting a little later activated than in left ventricular septal pacing. And if you go to selective left bundle pacing, you get a larger right ventricular desynchrony. And so here you see the left ventricular free wall and septum are synchronous because the left ventricle is synchronously activated. But you see some what we call reverse right ventricular free wall and septal flash, the positive part here, as we see. So how good or bad can that be? Well, there is some recent work from the group in Poland, from Jastrzewski's lab, and they measured with simple M-mode echo in a right bundle branch patient, what they called reverse septal flash, which you see here, and compared it to what you get with non-selective left bundle area pacing, and there you don't see that reverse septal flash. So his conclusion is that this difference can be explained by the fact that you also have an earlier septal activation from the non-selective left bundle area pacing. So in that sense, this non-selective may sound good, but it may actually be bad. And it's of course good to know that in many cases, chronically and even after a day, there's hardly any selective left bundle area pacing. It's pretty much all non-selective. So that's a positive sign. And this is even further illustrated by this study of Tian et al., also very recently published. He did a study in CRT candidates, but now look at the speckle tracking in the right ventricle and not the left. And he sees that there is quite a desynchrony also in the right ventricle, with the septum being abnormal, as you see here. And with LVAP, you get fairly nice resynchronization, again, thanks to this earlier septal activation by the non-selective patient. And he did a study where he looked at patients with no right ventricular dysfunction and compared it to right ventricular dysfunction patient as baseline. So in the patients without right ventricular dysfunction, but still all CRT, you see that they are large and that left bundle pacing has a well-known effect on volumes, on ejection fraction, and no worsening, no significant change, and actually slight improvement in right ventricular function. But if you now look at the patients with right ventricular dysfunction, they have larger ventricles. And that's also explained by the systolic pulmonary artery pressure. And so they have elevated pulmonary artery pressure, so elevated wedge pressures, showing the worst situation, like a backward heart failure, what you see. And in those patients, you see a significant reduction in SPEP by left bundle area pacing, and that systolic pressure reduction on the right side is also translating into a reduction in right ventricular volumes and an increase in right ventricular ejection fractions. So in those patients, left bundle area pacing is actually beneficial, but likely because of the improvement on the left side. So my conclusions would be that left bundle area pacing creates equal or better mechanical synchrony and function in both the LV and the RV, and both in bradycardia and in resynchronization pacing. The well-known LV improvement is to the physiological resynchronization, and even more physiological than bifi pacing. And interestingly, the RV improvement can be due to intra-RV synchronization in case of right bundle branch block, and to the reduced backward failure caused by the improved LV function. Thank you for your attention, and this is how I prepared myself to this meeting. I wanted to see the Great Wall before I came here. Thank you.